hypertension. Right. So whenever the patient has developed cirrhosis, and this cirrhosis has led to the portal hypertension, the most significant cause of mortality in these patients is the development of variceal bleed. So these cirrhotic patients, about one third of the cirrhotic patients, they die because of the variceal bleed. So as I told you yesterday that to label it as portal hypertension, the portal pressure gradient has to be more than 5 millimeters of mercury. The moment it is more than 5, it is said to be a portal hypertension. But for the varices to develop, it has to be anywhere in the range of 8 to 10 mmHg, right? Now, as I also told you that portal pressure gradient is the difference between the portal venous pressure and the hepatic venous pressure. Now, there is no way where we can put a catheter into the portal vein and measure the portal venous pressure. So that is why we indirectly measure this by using hepatic venous pressure gradient. Right? So I told you that the best way to measure this portal pressure gradient is transfemoral hepatic venous catheterization using a balloon tip catheter. So this is the best method to estimate the portal venous pressure. But most of the centers also use internal jugular vein. So whether you use internal jugular vein or you use the transfemoral vein route, the primary aim is to get into the inferior vena cava. Right. So now whatever route you entered into the inferior vena cava, from the inferior vena cava, you know that the right hepatic vein directly joins the inferior vena cava, but the left hepatic vein and the middle hepatic vein form a single channel, and this channel drains into the inferior vena cava. Now, this right hepatic vein, whenever you catheterize, either by using a internal jugular venous route or by using a transfemoral route, you try to enter selectively into the right hepatic vein. So, as you keep on going down, these right hepatic vein branches, and it keeps on branching and branching and branching until it reaches the sinusoid. Right? As I told you yesterday, the microscopic anatomy of the liver. So if these are the hepatic veins which are draining, and these are the branches of the portal vein. The point where they mix are the sinusoids. Right? So if you consider a hepatic lobule also, there is a portal triad here, and there is a central venule here. So the portal vein comes and empties its blood into the sinusoid here, and the hepatic artery comes and empties its blood into the sinusoid here, and through this sinusoid it enters into the central vein, and from there it is continuation as smaller hepatic veins which eventually form the hepatic vein. So when you introduce this catheter, you introduce this catheter through the inferior vena cava into the right hepatic vein and into one of these terminal branches of the hepatic vein. So you keep on passing them, and you keep on passing, and you try to get as close to the sinusoid as possible. Now here there are two methods. The first method is to use a balloon. Right? When you use a balloon tip catheter, you take the balloon and you place the catheter here only. Right? So the catheter is placed at the IVC only, within 1 to 2 centimeter of the right hepatic vein joining the IVC, and the balloon is not inflated, and you measure that pressure. Right? So that is pressure B, which is measured at the hepatic venous end by keeping it within 1 to 2 centimeter of the IVC, and it is deflated. You pass it further down outside 2 centimeter of the junction, and you inflate the balloon. And this inflated balloon, when the balloon is inflated, the pressure is measured. That is pressure A. So this A, which is measured close to the sinusoidal end, right? So the sinusoidal pressure basically represents the portal pressure. So now this is the portal pressure minus the hepatic venous pressure that gives you the portal pressure gradient, which is otherwise called as hepatic venous pressure gradient. This is one method. This is done in few centers, but in majority of the centers, what is done is a wedged hepatic venous pressure gradient. Right? So wedged hepatic venous pressure gradient is, as I said, you take this catheter and you pass this catheter down and down and down, and it reaches a point where it is closest to the sinusoid, and it is the terminal venule is so small that it cannot be passed further. So because it cannot be passed further, against this wedge, against the wall of this vein, it gets wedged. That is why it is a wedged hepatic venous pressure gradient, right? So you take the catheter, you pass it, you pass till it goes, and as long as it goes, and as it reaches the closest to the sinusoid, it cannot be passed further, and there it gets wedged. So this pressure, whatever you see, this is closest to the sinusoid, right? Because after the sinusoid, there is portal vein only, right? If you take this, it is passed up to here. It is closest to the sinusoid, and after the sinusoid, there is portal vein only. So measuring this pressure, this wedged hepatic pressure, is as good as measuring a portal venous pressure only. So that is why, because we cannot directly measure the portal venous pressure, we measure this hepatic venous pressure, wedged hepatic venous pressure, which is as good as measuring a sinusoidal pressure only, which is as good as measuring a portal venous pressure only, right? And then what you do is you take the catheter a little back. You pull it back so that it is freely in the hepatic vein, right? So you have taken it up to here, then you pull it back. When you pull it back, it is freely in the hepatic vein. So when it is freely in the hepatic vein, what pressure you measure there, that is closest to the inferior vena cava. So that is a free hepatic venous pressure, right? So the one that is closest to the sinusoid is a wedged hepatic venous pressure, which eventually represents the sinusoidal pressure, which eventually represents the portal pressure, right? And the one which is closest to the IVC, that is the free hepatic venous pressure, eventually represents the IVC pressures, which eventually represent the systemic pressure, right? So this is as good as saying the portal pressure gradient is the pressure difference between the portal venous pressure and the hepatic venous pressure, right? So this is portal pressure gradient, but in practice, it is nothing but a hepatic venous pressure gradient, which is nothing but the difference between the wedged hepatic venous pressure and the free hepatic venous pressure. Now, when you place this catheter and you place it here, as soon as you place it there, there are some variations in the pressure. So you need to allow it a little time so that it gets stabilized. The pressures get stabilized. So you wait around 45 to 60 seconds and you let the pressure stabilize and then you take the reading. So similarly, when you pull it back, because of the movement, the pressures vary. So once you pull it back and it is in the position, you wait for some 45 to 60 seconds and then you take the reading. So you take a total of 3 readings and you take the average of those readings that will give you the hepatic venous pressure gradient, right? So as I said, this hepatic venous pressure gradient should be between 1 to 5 millimeters of mercury. In other words, portal pressure gradient. The moment it becomes more than 5, you label it as portal hypertension, right? And the moment it becomes 8 to 10, there the portosystemic shunts start to open up, right? Though portosystemic shunts start to form. In other words, varices start to form when it reaches the range of 8 to 10. And the moment it becomes 12, then the variceal bleed starts, right? So if the variceal bleed has happened, it means that the pressure has exceeded 12 millimeters of mercury. When the pressure difference goes up to 16, there is increased mortality, right? And when it becomes 20, it means that whatever the treatment you have been, it remains at 20. It means that the treatment has failed or there is a high risk of death from variceal bleed, right? So normally it's between 1 to 5. The moment it is more than 5, it is labeled as portal hypertension. 8 to 10 is where the portosystemic shunts begin to form. 12 is the variceal bleed happens. 8 to 10 varices are formed, but they have high risk of bleeding once it crosses 12. And 16 is increased mortality. 20 is either a treatment failure or there's a high risk of death from variceal bleeding. So what did this help? Now, the portal pressure gradient or the hepatic venous pressure gradient, it helped us first to measure the portal pressure gradient. Right? Second is because we could measure it, we are able to define portal hypertension. Now, because we are able to define portal hypertension, we are also able to grade portal hypertension. Right? And also, after any procedure, after any intervention, if the pressures fall down, then we'll also be knowing about the prognosis of it. Right? Because you know that if it is 12, it is about to bleed. If it is 16, if it is about to bleed. And also, it tells us about the treatment effectivity. But most importantly, it tells us about how to differentiate a hepatic portal hypertension from prehepatic and post-hepatic, right? So it will help us to differentiate a prehepatic and post-hepatic hypertension. I'll tell you this how, right? Is it clear so far? Hello, hello.
Yes, sir.
So now, as we go from here, so prehepatic is the problem between the gut and the liver, and hepatic could be a pre-sinusoidal, it could be sinusoidal, or it could be post-sinusoidal, and then we have post-hepatic, right, which is the problem between the liver and the heart. Now we have wedged hepatic venous pressure. Remember, this is representing the sinusoidal pressure, which is in turn represent the portal venous pressure. And then we have free hepatic venous pressure, which is actually representing the hepatic venous pressure, which is in turn representing the inferior vena cava or systemic pressures. And then the difference of this is our hepatic pressure, venous pressure gradient or portal pressure gradient. See, I'll give an analogy. If there's a water in a plastic bottle and the lid is tightly closed, as you keep compressing this water bottle, the pressure in the bottle keeps on increasing. But the point of obstruction here is the lid. So because the lid is closed, whatever the pressure is built, it is built distal to the lid. So if you take the atmosphere pressure, it will be normal only. So whenever in the body, anywhere there is an obstruction, the pressure always builds distal to it. And proximal to the obstruction, there is no pressure at all. So in post-hepatic, what happens is this is liver and this is the heart. So the point of problem here is above the liver, right? You leave about Butchari because what happens in Butchari is there is a hepatic venous thrombosis. So whenever there's hepatic venous thrombosis, you cannot pass the guide wire till the distal hepatic vein only. So that is why in Butchari, this method is not done. What is done in Butchari is you do a percutaneous transhepatic. So directly through percutaneous or intraoperatively, you put a cannula through the liver and then you measure the venous pressure gradient. So Butchari is excluded in this. Now here the two other causes for the post-hepatic would be a congestive heart failure or there's a constrictive pericarditis. In both the reasons, the heart is not able to, in one, the heart is not able to push the blood forwards, so the blood builds upon. In second, the heart is not able to dilate properly so that it can take the blood in. So in both the cases, the blood builds up in the right atrium, which gets transmitted to the inferior vena cava and then to the hepatic veins, then to the liver, then down to the portal vein. So the point of obstruction here, or there is actually no obstruction, there's a functional obstruction, or the point of problem here is in the heart, which is above the liver, right? So obviously, if the problem is here, all the pressures downway, all through the portal vein, all the pressures will be increased. So what happens is in post-hepatic, the west hepatic pressure is also increased, and the free venous hepatic pressure is also increased, and both are increased simultaneously because the problem is neither in the liver nor below the liver. So because both of them are simultaneously increased and synchronously increased, the gradient becomes nullified, and that is why it remains normal. Right. Now, what happens is in pre-sinusoidal and pre-hepatic. See, pre-hepatic is what I told you that the most common cause of pre-hepatic is the portal venous thrombus. Right. So there's a thrombus in the portal vein, or there's a thrombus in the splenic vein. Right. So this is pre-hepatic, or in case of pre-sinusoidal, the most common cause is schistosomiasis. Next is non-alcoholic cirrhosis. In both of these cases, what I told is analogy of the water bottle. Right. So here the problem, you are measuring the pressure at the sinusoid and above the sinusoid, right? But the problem is below the sinusoid. Because the problem is below the sinusoid, here there is an obstruction. Now there is no point of sinusoid or the post-sinusoidal involvement here. So till there it is totally normal, right? So the point of obstruction is here. So distal to that pressures will be increased. So obviously in case of pre-hepatic or in case of pre-sinusoidal, the west hepatic pressure will be normal because the obstruction is distal to it. This will be normal. This is normal. This is normal. So definitely this will be normal, right? Now what happens in sinusoidal and post-sinusoidal? So in case of sinusoidal, the problem is at the sinusoid, right? So because the most common cause for both sinusoidal and post-sinusoidal is alcoholic cirrhosis. In sinusoidal, there is deposition of fibrin in the space of disc, and that is the reason for development of the hypertension. And sinusoidal pressure is increased. So if the sinusoidal pressure is increased, as I told you, sinusoidal pressure is nothing but the west hepatic venous pressure. So obviously this is increased, right? But free hepatic pressure, as I told you, the problem is at the sinusoid, and you are measuring pressure near the inferior vena cava or near proximally in the portal in the hepatic vein. So this has to be normal. So if this is increased and this is normal, so definitely this will be increased. Right? In post-sinusoidal, right? In post-sinusoidal intrahepatic, right? What happens in post-sinusoidal intrahepatic is that this post-sinusoidal again is mainly because of the alcoholic cirrhosis. And this alcoholic cirrhosis, there is destruction, there's formation of the regenerative nodules. These regenerative nodules will destroy the hepatic venules. So this is just about the sinusoid. Right? So the hepatic venules which are draining these sinusoids, they are destroyed. Because they are destroyed and any inflammation in the body results in fibrosis. So there is fibrosis around these veins. Because of fibrosis, the lumen narrows down, and that is why the wedged hepatic venous pressure is increased. But you measure the free hepatic venous pressure somewhere proximal, it is mostly normal. Or even if it is increased, it is slightly increased, not as much as this. And that's why this is also increased. So if you see this west have the portal pressure gradient is increased in case of a post sinusoidal and in case of sinusoidal measured by this method. And that is why this method is helpful to differentiate this hepatic cause of intrahepatic, intrasinusoidal and post-sinusoidal cause of portal hypertension from other causes of portal hypertension. Right. So this is the meaning of this table. Is this clear, or are there any doubts here?
Sir, I have one doubt, sir. Sir, the post-hepatic, you have said that both the wedged hepatic venous pressure and as well as the free hepatic venous pressure is raised. So how is the hepatic venous pressure there, like the gradient normal?
Yeah, that's right. See,
I'm a little
if,
confused on that part.
if this is 2 and this is 2, 2 minus 2 will be 0, right? If this is 3 and this remains 2, then it will be 1. If
Okay,
this is
minus 1.
3, if this is
All
3
right, all right.
and this is also
Okay,
3, it
okay,
will
sir.
be 0.
Okay, sir, got it.
No. Right. So is this clear? Hello, any other doubts? Then we'll move forward. So coming back from that deviation, we will proceed with variceal bleed. So as I told you, variceal bleed is the single most complication, life-threatening complication of a cirrhotic patient. And if there are cirrhotic patients, one third of these cirrhotic patients die because of the variceal bleed. And what determines mortality in patients with cirrhosis is functional hepatic reserve, right? So whenever a patient comes to you with cirrhosis, there are certain things that needs to be analyzed. So the first thing that needs to be analyzed, what is the underlying cause of the liver disease? What is the underlying cause that is resulting in the cirrhosis? And second is hepatic hemodynamics. Third is portal venous anatomy, right? And fourth is functional hepatic reserve. In fact, functional hepatic reserve is the single most important determining factor in mortality of these patients, right? So the most important factor that determines the mortality in patients with cirrhosis from the liver bleed is from the variceal bleed is functional hepatic reserve, right? And this is because if there's a patient who has got extrahepatic portal venous obstruction, like that liver is totally normal, but this child has got a portal venous thrombus. So in such patients, because the liver is totally normal, even if the variceal bleed occurs, as I told you yesterday, in cirrhosis, one aspect of the cirrhosis is development of portal hypertension. But the other major factor of cirrhosis is the functional parenchyma is slowly replaced by fibrous tissue so that the synthetic capacity of the liver reduces. As the synthetic capacity of the liver reduces, it cannot produce the factors that can stop this bleeding. So coagulative factors are not produced. So that is why if there are patients with cirrhosis, in these patients, if variceal bleed happens, the bleed is usually uncontrollable and results in more than 50% of mortality. But the patients with EHPO, even if variceal bleed happens, this is controllable because the liver is functioning fine. So rarely death happens in these patients. So that is why functional hepatic reserve is a major determinant of mortality in these patients. So when this variceal bleed happens, when the patient comes with a variceal bleed, now he's in a state of hemorrhagic shock, right? So it is a part of blood on the floor and forehead, right? So he's in a state of hemorrhagic shock, and the management remains on the same lines. First is you need to secure the airway, then you need to take care of breathing, then comes the circulation. Right? So circulation, as with any other shock, you secure two wide bore cannula and then you instill IV fluids. But here, because there is loss of blood, what about blood transfusion? Initially, they used to transfuse this blood when the HP fell to less than 9 gram per deciliter. Right? So when it used to fall to less than 9 gram of deciliter, they used to transfuse blood. But now what we practice is called as restrictive protocol. This was a liberal protocol. Here it is a restrictive protocol. So restrictive protocol tells you that you wait until the HP falls to less than 7 gram per deciliter. Right? So you don't have to, the moment it falls to 9, you don't have to transfuse it. You wait till 7, manage the hypotension, and when it is less than 7, you transfuse. Because with this, a lot of randomized control trials have told that this will reduce the risk of rebleed. Also, this will improve survival at 6 months. Right? The 6 monthly survival after a bleed and the reduction in the rebleed rates are much better with HB with a transfusion when it is following the restrictive protocol that you transfuse blood only when it is less than 7 gram per deciliter. Right? So once you transfuse, now you need to control the bleed. So control the bleed. Initially, in the very early days when this portal hypertension was being studied, most of them used to resort to surgery. But because the synthetic capacity of liver has already been compromised, there used to be a lot of bleeding, and the mortality is more than 25. Even nowadays, also, if surgery is done in acute setting of a variceal bleed, the mortality is more than 25%. So that is why the first line of the treatment for any variceal bleed is always non-operative management. Right? Non-operative management forms the first line of the treatment, and surgery is resorted in very few select cases where everything has failed. So in this non-operative management, there is pharmacotherapy, there is endoscopic therapy, then there is balloon tamponade, then there is stent, and then tips. Right? So all these are the options available, and depending upon the patient's presentation, we need to select these options. Right? Pharmacotherapy, whatever you choose, any of these you choose, pharmacotherapy forms a component of all of them. Right? So pharmacotherapy has to be initiated at the time of bleed. Right? So whenever, as soon as the patient comes to hospital, you need to initiate this pharmacotherapy. Right? See, the problem is there is a increased pressure in the portal system, which is diverted to the varices. And the most common site of variceal bleed is lower esophagus. As I told you yesterday, the major collateral would be a left gastric vein or a coronary vein. So it is the left gastric vein which is the major collateral, and lower esophagus is the commonest site of the bleed. Now what happens, because there is a lot of pressure in the portal vein, this is shunted towards these portosystemic shunts, and these varices keep on increasing in their size, and at one point they rupture and they start to bleed. Now, to control this bleed, we need to reduce the pressure. Right? As I told you yesterday, it all breaks down to two factors of portal hypertension pathophysiology. One is increased resistance, another is increased flow, right? So increased resistance is at the liver. Already cirrhosis has developed, fibrosis has developed, the resistance is there. You cannot do anything to the resistance. But the second factor is there is increased flow in the splanchnic circulation. In the portal circulation, the flow is increased. Why is the flow increased? I told you the reasons. So either because of splenomegaly or because of AV fistulas or because of hyperdynamic circulations or because there is splanchnic vasodilation, as the sensitivity to nitrous oxide and prostacyclins, as discussed earlier. All these are the causes where there is splanchnic vasodilation and the flow is increased, right? And because there is lot of blood in the portal system, and this portal system cannot go through the liver into the systemic circulation, it is finding other paths, that is to enter into these varices, and these varices structure and bleed. So our aim is to reduce this splanchnic circulation. Splanchnic circulation can be reduced by giving a splanchnic vasoconstrictor. So that is why we use somatostatin was used earlier, but now this somatostatin has been replaced with octreotide, because octreotide is a longer acting amyl. This is one. Even after this, the bleeding is not controlled, then you can use a terlipressin. So terlipressin is a vasopressin analog. Now this will cause splanchnic vasoconstriction, but this terlipressin also causes systemic vasoconstriction, right? So we should add a vasodilator for the systemic circulation. That is why usually whenever terlipressin is started, it is started with NTG. So NTG will contract the systemic vasoconstriction, while terlipressin keeps on causing the vasoconstriction of the splanchnic flow, so that it reduces the amount of blood in the portal system. So thereby reducing the bleeding. It's the same. So whenever you're doing surgery and the field is bleeding too much, we ask anesthetist to reduce the pressures so that the bleed reduces. The same principle. And third is, these patients are at high risk of infections. That is why antibiotic prophylaxis should be added. So this antibiotic prophylaxis will reduce the infection rate by more than 50%. And fourth, because the synthetic capacity of the liver is reduced, it is better to give vitamin K injections. And if it is not controlled, you can also transfuse FFP. Okay? So this is pharmacotherapy, which is instituted at the time of the bleed and has been a component of the non-operative management, whichever else along with the pharmacotherapy you choose. Now, what to do with these varices? So there comes the endoscopic therapy. In endoscopic therapy, two options are available: the endoscopic variceal band ligation and endoscopic sclerotherapy. Right? So, this endoscopic therapy, whether you use variceal band ligation or whether you use endoscopic sclerotherapy, it is able to control bleed in about 85% of patients. Right? But sclerotherapy is given into the varix and around the varix, and it causes fibrosis. There are reports that sclerotherapy can increase the portal hypertension and it can rebleed again. Right? So that is why sclerotherapy is not the first choice. So the first choice is always endoscopic variceal band ligation. So patient is taken to the endoscopy suite, and if needed, intubation is done to protect the airway. Then esophageal intubation is done. A good wash is given. The bleed is identified, and a rubber band is deployed at the base of the varix, which will control the bleed. Right, and this endoscopic variceal band ligation, along with pharmacotherapy, is the treatment of choice. Right, so the treatment of choice in an acute variceal bleed is pharmacotherapy with endoscopic band ligation. Right, endoscopic band ligation will control the bleed in about 85% of the patients. But in some patients who are bleeding so much that even if you give wash also, you are not able to find the varix, because you cannot find the varix, you cannot put a deploy a band onto the varix. So if such is there, by the time you find the varix and you deploy band onto the varix, the patient will have go into the hemorrhagic shock and cardiac arrest. In such patients, to arrest bleeding and to attain hemodynamic stability, so the hemodynamic stability has to be attained. Along with that, the bleeding has to be stopped, arrested, which has to go side by side. So in such patients, it is advisable to use a balloon tamponade. So the device, the tube that they designed was a esophagogastric tube, So they designed a esophagogastric tube and they added two balloons to it. One was a gastric balloon and the other was a esophageal balloon. And then the esophageal balloon had a separate chamber for its inflation. The gastric balloon had a separate chamber for its inflation, and both of them had a measuring meter, right? So now this balloon is inserted into the stomach, and the this tube is inserted into the stomach, and this is the gastric balloon. The gastric balloon is inflated with 300 ml of air, and once it is inflated, it is pulled back so that it comes and it sits at the fundus of the stomach. And after that, the esophageal balloon is inflated to the pressure of 60 mmHg, right? So that this will compress the varices because you are not able to find the varix so that you can control the bleed. You put this tube and the entire column of the esophagus and stomach is inflated with a device that will press the varix against the wall of the esophagus and the stomach so that it will effectively control the bleed. For it gives good amount of compression and you make the patient hemodynamically stable and then you go again with endoscopy, right? So one more thing I forgot to tell is endoscopy has to be done as early as possible, preferably within 12 hours of the admission. Right? So once you put this balloon, you need to confirm it radiologically. And after you confirm it radiologically, every 12th hour, you need to deflate it because if you don't deflate it, that will lead to the pressure necrosis of this. So this balloon, they called it as Sangstecken Blackmore tube, right? SBT. Right. So to this, they added one more channel, right? So they added this channel, which was a aspiration channel. So if at all some blood comes out, it could be aspirated out. So this aspiration channel was added to it, which is esophageal and gastric aspiration channel, and then they called it as modified Sunstick Blackmore tube. Right? So the difference between Sunstick Blackmore and modified Sunstick Blackmore is that a new esophageal and gastric aspiration tube was added, and this is also called as Minnesota tube. Right? Modified Sunstick Blackmore tube is also called as Minnesota tube. Now, even this balloon tamponade is able to achieve the control of bleed in about 85% of the patients. But the problems with this balloon tamponade is one, discomfort, right, to the patient. And second is pressure necrosis. At 12 hours, if you don't deflate it, forget to deflate it, it will lead to the pressure necrosis. But the problem is when you deflate it, more than 50% of these patients will rebleed again. So these are some of the problems with the balloon tamponade. Nevertheless, when endoscopic therapy has failed, it is a very good adjunct till the patient gets hemodynamically stable. So one more aspect of that is a stent. Right? So nowadays, this is the esophagus. There is a varix over here, which is bleeding. Multiple varices are there, but you are not able to identify the source because it is bleeding heavily. So you can deploy a stent here and you can expand the stent. So as you expand the stent will press onto the walls of the esophagus and give adequate compression so that the bleeding stops until you can achieve hemodynamic stability. So that is a self-expanding covered esophageal stent. Right? So the problem with this stent is that this stent is used only for the esophageal varices. If there's a bleed from the gastric varices, again this stent cannot be used. Right? When all of this fail, right? So the attempts, what are we doing here? The first pharmacotherapy, we are trying to reduce the flow to the in the portal system. By endoscopic therapy, if something is bleeding, we are trying to catch hold of it and stop its bleed. If all of this fail, then earlier what they used to do is the only way, right? The same analogy, when you compress the bottle against a closed cap, the pressure is increasing. So whatever you do, the pressure is not decreasing. So the only way to decrease the pressure is to let the water out, right? You make a hole onto the bottle, you let the water out somewhere, the pressure will come down automatically. So similarly, earlier surgeries were done where because there is an increased pressure in the portal vein, and this pressure in the portal, this blood in the portal vein somehow has to reach the inferior vena cava. Earlier it was going through the liver, but because it is not able to go through the liver now, we shall bypass it and we shall directly connected to the inferior vena cava. So that is the concept of a shunt, where we surgically create a bypass between the portal venous system and the systemic venous system, so that the portal system is decompressed and all the varices will come down. So that is most effective way. But as I told you, there was surgery was resulting in a high mortality. They devised a radiological way, interventional radiological way to combat this. So that is what is TIPS. Right. So what is TIPS is? TIPS is transjugular intrahepatic photosystemic shunt. Right. So you go, it is done under sedation only. You can give some analgesia and local anesthesia, and you cannulate the intrajugular vein, preferably the right intrajugular vein. From there, you will go into the innominate vein. From the innominate vein, you enter into the SVC, and from the SVC, you enter into the right atrium. From the right atrium, you go into the inferior vena cava. So from the inferior vena cava, you go into one of the hepatic veins. So, for example, you pass this catheter into the hepatic veins. This is the hepatic vein, and this is the branch of this is the portal vein, right? So now what you do is, earlier what used to happen, this is the hepatic vein, there is the sinusoid here, and then there's a portal vein here. The blood flow is not possible here because of the sinusoidal obstruction. So you put a stent here. So that is what it is TIPS. So it is transjugular intrahepatic photosystemic shunting. Right. So then you pass a guide wire through this and you pierce the hepatic parenchyma from the hepatic vein and enter into the portal vein. Right. So you pierce it and enter this guide wire into the portal vein, and then you use a balloon to dilate this tract. And once the tract is dilated, you will put a stent here, right? And then you confirm. And now you are bypassing the sinusoid. So the problem is at the sinusoid. You bypass the sinusoid. You connected the portal vein directly to one of the hepatic veins. So that is why it is transjugular intrahepatic photosystemic shunts. I'll tell you what are the advantages of this. So one major advantage is you have decompressed. So as soon as the portal vein is connected to the hepatic vein directly, all the blood which was not going through the liver now easily will go into the right hepatic vein, into the inferior vena cava, into the IVC. So that is why it effectively decompresses the varices. So all the varices are gone now. That is one. And second is the reason that patients with cirrhosis develop ascites is that. So this is liver. So the portal vein is formed by the superior mesenteric vein and the splenic vein, and then there is inferior mesenteric vein. So this is splanchnic circulation. So because there is a block here, the liver cirrhosis. One reason for development of ascites in these patients is because of low protein. The second reason is if there is any vessel here. Now, what keeps fluid within this vessel depends upon the two forces, colloid oncotic pressure and hydrostatic pressure. Now, colloid oncotic pressure is something that will draw the fluid inside. Now, this is largely dependent upon the hemoglobin and albumin. Now, chronic liver disease, both hemoglobin and albumin are reduced. So, because they are reduced, there's nothing to draw the fluid inside, and fluid naturally has the tendency to move outside. Along with that, there's one more pressure called as hydrostatic pressure. Now, hydrostatic pressure is the pressure exerted by the column of this blood onto the walls of the vein. Right? So, this always tries to push the blood outside. Now, because there is a obstruction here, the pressures are increased here already. The portal pressure, the mesenteric pressures are already increased here, and the colloid oncotic pressure is reduced, as a result of which all the fluid will seep out, and that leads to ascites. Right? So just like in case of DVT, there's swelling of the limb. So similar case. So whenever there is obstruction, distal to that, hydrostatic pressure is increased. Here, along with the hydrostatic pressure, the colloid oncotic pressure is reduced. That will lead to ascites. The moment you bypass this and let the blood, all this blood will run off into the hepatic veins. As it runs off into the hepatic veins, the hydrostatic pressure will reduce and ascites will come. So all this tips is where The varices are effectively decompressed, and it is very good if the patient has got intractable ascites. So ascites is also taken care of. But what are the disadvantages with these tips? So the main complication of tips, immediate main complication of tips is that because you are taking a guide wire and passing it through the hepatic parenchyma, there is injury to the capsule, and this can lead to the intraperitoneal bleeding. Right? Liver is highly vascular, that can lead to the intraperitoneal bleeding. This is first. Second is basically what you're doing is you are bypassing the liver. Right? The problem was with the liver, you bypass the liver and the blood has entered into the hepatic vein, decompressed the varices, fine. But the point of blood flowing through the liver is, or whatever we eat, everything has to get digested and absorbed in the gut. And from the gut, until it gets detoxified in the liver, it is not put into the systemic circulation. Right? So liver is protecting us from whatever we eat, whatever the toxins we eat, liver is protecting us. So the moment you bypass liver, all these toxins will definitely enter into the systemic circulation unchecked. Because it enters into the systemic circulation unchecked, that will lead to encephalopathy. Right? So this is common for all the non-selective shunts. So in case of tips, the encephalopathy rates are as high as 40%. Right? So it leads to increased risk of encephalopathy. And third, because the hepatoportal flow is blocked here, right? From the portal vein, it directly goes into the liver. The flow to the liver is blocked. So because of this, what happens is the hepatic derangement further progresses, right? So these are the problems. One is the most common complication is the injury to the capsule, which leads to bleed. Second is because the liver is not detoxifying the toxins, there is increased risk of encephalopathy. And third is there is hepatic derangement. And fourth is little controversial, that is in patients with DCLD. So in patients with DCLD, if TIPS is done, it is observed that the 30-day mortality is increased. Right? So TIPS, if done in DCLD patients, 30-day mortality is increased. But it is observed that in patients with DCLD, if the variceal bleed happens, you try to control it with pharmacotherapy, then endotherapy, then balloon tamponade. If all these fail, then you do TIPS, the 30-day mortality is increased. But in a patient with DCLD, you directly do TIPS. It is actually adding to their survival. Right? So this is little controversial, and it has to be yet decided which is the best course. But if at all TIPS is being considered in the DCLD, it has to be done as early as possible and not to wait till other surgeries fail, other modalities of the treatment fail. Right. And now the contraindication to TIPS. Right. So if there is a thrombus in the portal vein, the thrombus is here, you are bypassing it here. There is no point that it decompresses because the thrombus is here. The pressures still remain high. So a portal venous thrombus is a contraindication to the TIPS. That is why before proceeding with the TIPS, it is, I told you that portal venous anatomy has to be studied. Abdominal Doppler is done to exclude the thrombus in the portal vein, and only once it is excluded, it is done. So the current indication for TIPS in acute variceal bleed is failure of endoscopic therapy, combined pharmacotherapy, and balloon tamponade. Right? So failure of this therapy is an indication for the TIPS in a patient with acute variceal bleed. Right? So there is second part of the TIPS, that is the indications of TIPS in a chronic endoscopic therapy failure and chronic complications, long-term complications of TIPS that we will discuss later. Right? So is this clear till now? Hello.
Yes, sir.
Now, if everything is failed, the last resort, even if TIPS is failed, the last resort is surgery. Right? So, what are the indications for surgery in a acute variceal bleed? Right? So, if the patient has got acute variceal bleed and this patient fails to respond to pharmacotherapy and the endoscopic therapy, and in this patient, TIPS is either contraindicated or TIPS is failed. So, such patients, you need to take them for surgery. Right? So surgery can be a portocable shunting, or it could be a complex shunts like distal splenorenal shunt. So if the patient is actively bleeding at the time of surgery, you go with a portocable shunting. If the patient's bleeding is controlled at the time of surgery, you go with complex shunts like distal splenorenal shunt. But whatever shunt you do, the mortality is more than 25%. And this mortality again depends upon one single most important factor, it is functional hepatic result. Right? So that is why surgery is reserved only when TIPS is contraindicated and failed and all other modalities of treatment have failed. So this is about the acute management of variceal bleed. Now, once the variceal bleed is controlled, the very important thing that needs to be kept in these patients is these patients can go to rebleed again. Right? So more than 70% of patients who have bled have the risk of rebleeding. And this risk of rebleeding is highest in first few days. And it slowly keeps on decreasing and the risk reduces by 1 year. So there's significant reduction in risk by 1 year. And after this, annually, it keeps on reducing by 15%. So the highest in first few days, and after 1 year, annually it keeps on reducing by 15%. So from variceal bleed to rebleed, whatever this prevention is there. So this is nothing but secondary prophylaxis. Right? So secondary prophylaxis is that the patient has already bled, but we need to stop. We need to prevent rebleeding in these patients. And the first line treatment or the treatment of choice in the patients for secondary prophylaxis is again combined pharmacotherapy plus endoscopic therapy. Right? In endoscopic, it is variceal band ligation, and pharmacotherapy is you add a beta blocker so that it reduces the overall output to the splanchnic circulation and also the rate at which this blood is put into the splanchnic circulation. Along with that, you can also add isosorbate 5 mononitrate. Right? So, along with that, variceal banding. This is the first line treatment. Now, when the patients are managed with endoscopy over a long period of time, about one third of these patients fail endoscopic therapy. Right? So, when the patients fail endoscopic therapy, you need to switch to some other models of treatment. So, what are these indications? Is when there is multiple episodes of rebleed. One or two episodes of rebleed can be again managed with endoscopic band ligation, second time, third time. But 4 or 5 times of rebleed, you need to reassess and switch to some other modality. Second is when there is uncontrolled bleed. And third is if there are portal hypotensive gastropathy or gastric varices, right? So in case of gastric varices or uncontrolled bleed or multiple attempts of rebleed, multiple episodes of rebleed, so it is better to consider some other modality of the treatment. Right? That would bring us back to tips again. Right? So what are the indications of tips? So the indication of tips was one when there is acute variceal bleed which is not responding to pharmacotherapy and endoscopic therapy. Second is TIPS is indicated in a long-term endoscopic therapy failure. Third, it is indicated in a medically intractable ascites. You know the reason already. Fourth, if the patient has got a variceal bleed and is awaiting liver transplant, right? So till the liver transplant, he is a candidate for liver transplant. He is awaiting liver transplant, and till the time for liver transplant for this short-term decompression. So these are all the candidates for TIPS. Right? So I told you about the short-term complications of TIPS. Now I want to tell about long-term complications of TIPS. Right? So the long-term complication, the major complication of TIPS is that there is shunt occlusion. Now, this shunt occlusion can either be because of shunt stenosis or because of shunt thrombosis. So, the development of stenosis is much more common than thrombosis. And this shunt stenosis occurs because of intimal hyperplasia, right? So the intima of the blood vessel grows through the shunt and it undergoes hyperplasia and it blocks the shunt. So in such cases, the first line of treatment would be to do a balloon dilatation. And if balloon dilatation fails, you can go ahead with the replacement of shunt, right? So now this shunt occlusion occurs in about 50% of cases, about half the cases by end of 1 year. So by end of 1 year, about half the cases treated with tips undergo shunt occlusion, right? So this is about tips. Now comes the important part about surgery, right? Surgery as a second prophylaxis. So the overall indications for surgery would be, as I told you again, one, acute variceal bleed, where the patient is not responding to the pharmacotherapy with combined endoscopic therapy and TIPS is not possible or contraindicated. Second is again long-term endoscopic therapy failure and TIPS is failed or contraindicated. Third is if there's a non-cirrhotic liver with extrahepatic portal venous obstruction. Right? So the problem is not in the liver; it is before the liver. So surgery is the best option for such patients. So non-cirrhotic liver with extrahepatic portal venous obstruction. And fourth is, as I said, left-sided portal hypertension. So I told you yesterday about the left-sided portal hypertension. So what happens in left-sided portal hypertension is there is portal vein formed by the superior mesenteric vein and the splenic vein. There's a thrombus in the splenic vein. So that there is splenomegaly, and this splenic vein is left gastroepiploic vein drains into the splenic vein, and this will lead to the gastric varices. So this is because it is entirely restricted to the left side. It is also called as left-sided portal hypertension, and in such patients, splenectomy with removal of this vein and the thrombus is the treatment of choice. Right? So in all these cases, surgery is indicated. By surgery, I mean it is shunts. Right? So these shunts are divided into non-selective shunt, selective shunt, and a partial shunt. So the basic principle is the problem is that the liver, the blood, portal blood is not going into the liver. So you need to put it into inferior vena cava by some other means. And what means you use is called as a shunt. So depending upon how you do it, it is classified into non-selective, selective, and portal shunts. I, I even though yesterday I told in detail about the portal venous anatomy, I just want to tell it once more, right? So that this will be helpful for understanding the shunts. So this is cecum, then there is small bowel and appendix, right? And then there is transverse colon, left-sided colon, then sigmoid colon, right? So there is ileal vein, and there is cecal vein together forming ileocolic vein. Then there is right colic vein, then there is middle colic vein, and there are ileal veins, jejunal veins. So all these form the superior mesenteric vein, right? It is a superior mesenteric vein and drains the inferior pancreaticoduodenal vein. On this side, the superior rectal vein, right? Because the superior rectal artery is a continuation of the inferior mesenteric artery. So the first vein would be a formative tributary would be a superior rectal vein. To this joins the sigmoidal vein, and to this joins the left colic vein, which together form the inferior mesenteric vein. Now, this inferior mesenteric vein will drain into the splenic vein. Right? So, this is splenic vein into which inferior mesenteric vein drains. The pancreatic veins, there are multiple pancreatic veins which drain into the splenic vein, and splenic vein has its formatory tributaries from the spleen. Right? And then there are gastric veins, short gastric veins, which drain into the splenic vein. Right? So this splenic vein and the supramesenteric vein behind the neck of the pancreas, they form the portal vein. This portal vein at the hilum of the liver divides into the left branch and to the right branch, right portal vein and left portal vein, right? So I'm not going to tell further about this. So this is how a portal vein is formed. Now there are few important structures here and the way they are drained. So the lesser curvature is mainly drained by an important vein, which is a left gastric vein, which anastomoses with the right gastric vein. So the right gastric vein and the left gastric vein, anastomose, both of them drain into the main portal vein. They can also drain into the left portal vein. They can also drain into the supramesenteric vein, right? Because this left gastric vein forms a circle, it is also called as coronary vein. So that is the reason. Coronary means circle. It forms a circle because it anastomoses with the right gastric vein. It is a coronary vein, and this is the major collateral. Right? Now, the greater curvature, these are the short gastric veins. They have become too long here. So these are the short gastric veins which drain into the splenic vein. These are the pancreatic veins which drain into the splenic vein. Inferior mesenteric vein which drains into the splenic vein. Right. Now then there is a left gastroepiploic vein which is draining the greater curvature of the stomach, and this left gastroepiploic vein drains into the splenic vein. And then it anastomoses with the right gastroepiploic vein. This right gastroepiploic vein does not drain into the splenic vein. This comes all the way here, and this right gastroepiploic vein, superior pancreaticoduodenal vein, and superior right colic vein. Right, so superior pancreaticoduodenal vein, superior right colic vein, and right gastroepiploic vein together form what is called as gastrocolic trunk of Henle. And this gastrocolic trunk of Henle drains into the supramesenteric vein, right? So this is what we discussed yesterday. Now here I want you to understand and remember this. One is the most important left gastric vein, which drains into the portal vein or into the left portal vein or into the supramesenteric vein. The right gastroepiploic vein drains into the superior mesenteric vein eventually. Right? The inferior mesenteric vein drains into the splenic vein, while the left gastroepiploic vein drains into the splenic vein. The small pancreatic veins and also a big pancreatic vein drains into the splenic vein, but the inferior pancreaticoduodenal, superior pancreaticoduodenal drain into the superior mesenteric vein. Right. So is this clear? Hello? Hello? Hello?
Yes.
So keep this anatomy in mind. With that, we'll start the shunts. So the first described shunt was a non-selective shunt, and it was described by Eck, right? So Dr. S described this shunt where this is liver, this is supra-hepatic part of the IVC, this is infra-hepatic part of the IVC. Then there was this portal vein, the right and left branches, and the portal vein, supramesenteric vein, and the splenic vein. Right? Now, because there is problem here, this is the area of problem, he wanted to bypass this. So what he did is he ligated this vein at the hilum of the liver, and he diverted this portal vein to the inferior vena cava. Right. So this is liver, the portal vein at the hilum was ligated, and the supramesenteric vein, splenic vein joining the portal vein. This portal vein was taken, and this portal vein was inserted into the infrahepatic part of the IVC, right? So that is why this is end of the portal vein. This is side of the IVC. So Eck fistula is a end to side portocaval anastomosis, right? So we took this. Now what happens? Because the major tributary of this was a left gastric vein, and left gastric vein used to cause the varices here. Now, because this is decompressed, now all of this blood from the varices will flow back into the portal vein. From here, it will go into splenic vein. It will flow back into portal vein. From portal vein, it will directly enter into the hepatic vein, sorry, inferior vena cava, and it goes upwards. So this diverted. So because of this diversion, all the varices were decompressed, and ascites was also taken care of. But the problem happened in a Budd-Chiari syndrome. So in Budd-Chiari syndrome, what happens is there are these hepatic veins which are eventually draining into the liver. Now there is a thrombus in these hepatic veins. Now because there is a thrombus in the hepatic veins, the blood wouldn't go here through the hepatic veins. So that was the reason it used to flow backwards, and there was portal hypertension. Now if you block here, what happens? Neither the blood can go into the hepatic veins because there is a thrombus, nor the blood can come back into the portal vein because you have blocked the portal vein. So because of this, the liver used to get congested. Liver was not decompressed at all, and there was huge hepatomegaly. Right? To solve this problem, what they did was there was another idea where they did not do end-to-end anastomosis, but they did a side-to-side anastomosis. Right? So now they did the side-to-side anastomosis. So with this side-to-side anastomosis, there was a channel that was opened here. All the blood from the portal venous system entered into the inferior vena cava where it was decompressed. And because the liver blood, which could not enter into the hepatic vein, it also entered into the portal vein. Because all this portal vein was decompressed, the pressure is reduced. Just like water, the blood also follows the path of least resistance. So because this is a path of least resistance, here there is a lot of resistance, it will come back into the portal vein, and through this fistula, it will enter into the IVC and it will get decompressed. So the liver was also decompressed, the varices were also decompressed. So this is a end to site, side to side portocable anastomosis. Right? So this was end to side portocable anastomosis, and this was side to side portocable anastomosis. And along with that, there are some other shunts. So if this is the liver, and then there is inferior vena cava, and draining into this inferior vena cava is a renal vein, right? And we have our port vein here, supramesenteric vein, splenic vein, and the portal vein. So this was mesenteric vein, this is renal vein. So this is supramesenteric vein, this is renal vein, and this is inferior vena cava. Now, anastomosis, side to side anastomosis was done between a supramesenteric vein and the inferior vena cava. So that was called as mesocaval shunting, or from the supramesenteric vein and into the renal vein. This was called as mesorenal shunting, right? So either a mesocaval or a mesorenal shunting was done, which is again effective in decompressing the liver, right? So a little complex surgery of that was a splenorenal shunt. Now, what happens in a splenorenal shunt is assume that this is kidney. So here is the splenic vein from the spleen. The short gastric veins drain into the splenic vein. The left gastroepiploic vein drains into the splenic vein. Pancreatic veins drain into the splenic vein. Inferior mesenteric vein drains into the splenic vein. And then there is supramesenteric vein, and this forms the portal vein. Right. So here, what they did is, and then these are the left gastric veins and the right gastric vein. In conventional splenorenal shunt, which is nothing but a proximal splenorenal shunt. You need to understand here the terms proximal and distal are in reference to the spleen, right? So if the vein is cut close to the spleen, it is called as a proximal splenorenal shunt. If the vein is cut close to the port vein, it is called as a distal splenorenal shunt. So it is with respect to the proximal. So here, what they did is they eliminated spleen, right? So first thing is splenectomy was done. And as they did splenectomy, the proximal splenic vein, they took the proximal splenic vein and they anastomosed into the left renal vein. So that is why it is a proximal splenorenal shunt, which was done for years together. So that was the conventional splenorenal shunt, right? So splenectomy was done and the proximal splenic one was taken and given to the left renal vein. So now what happens? The problem is here. So because the problem is here, there is a lot of hypertension which goes to the left gastric vein and it is causing varices here. Now because of this, all the blood will be shunted to the through this shunt into the splenic vein, and from the splenic vein it will enter into the inferior vena cava. So as it enters into the inferior vena cava, the pressure here falls down. So whatever the blood was there at the varices, this blood will enter into the left gastric vein. From there it will come into the portal vein, and all the blood from the gut will come into the portal vein. Now this is a high pressure zone, but this is a low pressure zone. So the blood will go back again into the splenic vein. So from the inferior mesenteric vein also the blood will go back into the splenic vein, and this keeps on going here. The blood also is received from the gastric veins. From there, it will find this path where there is less resistance. It will pass through the shunt and it will get back into the inferior vena cava. So this way, all the varices would be effectively decompressed. So that is the proximal splenorenal shunt. But the problem is splenectomy is done. So this leaves patients vulnerable to OPSI. This is first problem. And second problem is the splenic vein, when it forms, it is a small caliber vein. As it keeps on going forward, the caliber of the splenic vein keeps on increasing. So the diameter of this vein keeps on increasing, right? So, but here, if you take this vein as a graph, the vein has got a narrow lumen. Because the vein has got a narrow lumen, there are high chances of thrombosis, right? Because the proximal vein is of smaller caliber, this vein will undergo thrombosis eventually. So when this vein undergoes thrombosis eventually, again the pressure system here is increased. So this blood will not go downwards, but it will rather go upwards and it will again form the varices. Right? So this is about splenorenal shunts. So if I want to summarize this, the non-selective shunts are the shunts where they entirely decompress the portal and the mesenteric venous system. They bypass the liver and empty the blood into the inferior vena cava, or a tributary of the inferior vena cava. So the first described by Eck was a end to side portocaval shunt, and then there was side to side portocaval shunt, and then there were mesocaval and mesorenal shunts of larger diameter, and then fourth is a conventional splenorenal shunt, which is a proximal splenorenal shunts. So all these are non-selective shunts. In a way, TIPS is also a non-selective shunt, right? Because you are connecting the portal vein to the hepatic vein directly. So all these are non-selective shunts. The advantage, these non-selective shunts have got advantages. The main advantage of this non-selective shunt is that they will effectively decompress. Right? So the first line of treatment for secondary prophylaxis would be pharmacotherapy with the endoscopic therapy, but the most effective way of decompression of this varices would be the non-selective shunts. And second is they will take care of this ascites. So they will decompress the system and they will take care of the ascites. But again, the disadvantage is because they completely steal the blood away from the liver, they will reduce the hepatoportal flow. So because they reduce the hepatoportal flow, because what happens is, if once this shunt has happened, in this system the pressure has reduced, all the blood will come through this and it will enter into the IVC. So the liver is totally bypassed. So when the liver is totally bypassed, because of this reduction in the hepatoportal flow, that leads to increased risk of encephalopathy and also increases the rate of degeneration of the liver. Right. So the liver disease keeps on progressing and there is increased risk of encephalopathy because the hepatoportal flow is diverted. But the advantage is they will decompress and they will relieve the ascites. So because of these reasons, now this is rarely used. What now we use is a selective shunt. Right. Now, what to do in a selective shunt is that the hepatoportal flow has to be preserved. At the same time, you need to block the varices. So you need to decompress the varices, but at the same time, you need to preserve the hepatoportal flow. So for that, there are two shunts. One of the selective shunt is a Warren shunt, and another is a Inokuchi shunt. Right. So this Warren shunt is nothing but a distal splenorenal shunt. Right. Now, so it is a little complex procedure. A distal splenorenal shunt. So, I hope you remember the anatomy. This is spleen. So spleen, stomach duodenum, renal vein, inferior vena cava, and this is the portal vein. So here, this is the left gastric vein, which is the major collateral, and then there are short gastric veins which drain into the splenic vein, left gastroepiploic vein, which drains here. Now, what the selective shunts do is, as soon as you decompress this system by doing enough the above, as I said, this will reduce the flow in this hepatoportal system and the blood will rush backwards to this and the liver does not get any blood. Now the aim is to keep the some amount of blood flowing through the liver, right? So that liver will toxify and yet you decompress this. So the left side of the system has to be decompressed, yet the hepatoportal flow has to be preserved. So for that, what they did is instead of cutting the hepatic vein, the splenic vein near the spleen, so what they did is they split the vein close to the portal end, right? So they cut the portal vein close to it, and they brought this renal vein and anastomosed. They brought the splenic vein and anastomosed the renal vein, right? So in the proximal splenorenal shunt, the splenic vein was cut close to the spleen and the proximal splenic vein was used, but here the distal splenic vein is used. So it is cut close to the portal end and it is anastomosed to the renal vein. So this is one. But the second important aspect of this is they wanted to do a gastrosplenic disconnection. You disconnect the entire gastrosplenic drainage system from the supramesenteric venous system and the portal venous system, right? So because what happens when if you do like this and leave it off, the blood will come from the this vein, from the portal vein, the blood will come here and it will go and it will enter into these varices here. From then it will be drained through the short gastric veins. It will come here, it will go back and it will drain back into the splenic vein. So again, the hepatoportal flow will be lost. So that is why to prevent that, they cut these left gastric veins. They cut the gastroepiploic veins and they cut these small the pancreatic veins that used to drain into the spleen. They cut this splenic pancreatic veins, right? So all these are cut. So what happens then is this is liver, stomach and duodenum, spleen, Then there is inferior vena cava, renal vein. Then this is the portal vein. The supramesenteric vein is fine. And then this left gastric veins were cut here, right gastric veins were cut here, and the splenic vein was transected here. So now this splenic vein enters into the renal vein. This is inferior mesenteric vein, and this continues splenic vein up to the spleen, right? The short gastric veins enter here, and the left gastroepiploic vein was also cut. It was disconnected. Most of the pancreatic veins get disconnected, right? So the left gastric vein was disconnected. The main splenic vein was disconnected from the portal system. The gastroepiploic veins were disconnected, and most of the pancreatic veins were disconnected. So now what happens is, now there is no way that the blood which comes back here, this blood cannot go through the gastric veins into the stomach. So whatever the blood that was stayed here, it will be drained via stomach, via the short gastric veins. It will drain back into the splenic vein. The blood from the inferior mesenteric vein will also drain into the splenic vein. From the splenic vein, it will come through this shunt and it will enter here. So this entire system is decompressed now. So the esophageal varices, gastric varices, they cannot drain by the left gastric vein because it is cut there. Now they are forced to drain through the short gastric veins, which eventually drain into the splenic vein. The inferior mesenteric system is also drains into the splenic vein, and this entire left side of the system will be drained through the renal vein so that it will go into the uh, inferior vena cava. Now let us see what are the advantages of this. Now the first advantage of this is spleen is preserved. Now because spleen is preserved, the risk of OPSI is eliminated. Right. And second, you are using a large caliber vein. So because you are using a large caliber vein, the risk of occlusion is reduced. And third, there is gastrosplenic disconnection is done. So in this gastrosplenic disconnection is done. So the gastrosplenic system is completely disconnected from the supramesenteric system and the portal venous system. So because of this, there is effective decompression of varices. But why did we do it? The main reason for this is to preserve the hepatoportal flow. Right? So you need to preserve the hepatoportal flow. So by this, what happens is, thus all the blood from the superior mesenteric, from the inferior mesenteric vein, whatever the blood is drained, it will go into the splenic vein and it will drain into the renal vein and it is gone. But the blood that comes into the superior mesenteric vein, it goes here through the portal vein, it goes to the liver. Now, because of the portal hypertension, even if the blood has to come back, there is no way for this blood to go. Now, it cannot go through these left gastric veins because they are cut. It cannot go into the splenic vein because that is cut. So the only way is the blood will remain here. And the only way for the blood to go is through this liver, right? So because of, by disconnecting the splenic vein and all the gastrosplenic components from the mesenteric and the portal system, there is no way for the blood to escape, and the blood remains into this portal vein and the superior mesenteric vein so that the portal pressure is maintained. The superior mesenteric venous pressure is maintained, and with this pressure, some amount of blood is still moving forward through the liver. So that there are two things that happen. One is there is the hepatoportal flow is maintained, that is one, and second is that there is a effective decompression of the varices. So these are all the advantages of the distal splenorenal shunt, but also there are certain disadvantages. The first disadvantage is the reverse of non-selective shunt. Because the pressure in the superior mesenteric vein is maintained, because there is high hydrostatic pressure in the superior mesenteric vein, there is high risk of ascites, right? In fact, one of the contraindications for distal splenorenal shunt is ascites, right? Because this is not the pressure in SMV is not reduced, it is maintained, and there is high risk of ascites. And if the patient also has ascites, already has ascites, it is a contraindication. One more contraindication is if the vein diameter is less than 7 mm, there are high chances that it will undergo occlusion, right? So, splenic vein caliber diameter of splenic vein, if it is less than 7 mm, it is a contraindication. It has to be at least 7 mm. Second is this hepatoportal flow, whatever is there. Now, this hepatoportal flow will be lost. Now, what are the reasons? What are the factors that result in loss of hepatoportal flow? Right? The main reason of doing this was to preserve the hepatoportal flow, but that will be lost in certain conditions. First is if you fail or if you omit coronary vein ligation, right? So if you do not ligate this coronary vein, all the blood will come back, will escape through this coronary vein. It will go into the stomach and it will come back here and it will come back here. And because now this is a path of least resistance, all the supramesenteric venous blood and the portal venous blood will drain into the left coronary vein. From there, it will go into the stomach and it will come back into the splenic vein. So if you do not effectively ligate the left gastric vein, or if you omit the ligation of the left gastric vein, that is going to result in a loss of hepatoportal flow early. Second is early loss of hepatoportal flow is seen in patients with alcoholic cirrhosis, right? So those patients who have developed the alcoholic cirrhosis and these patients keep on drinking even after such a major surgery, that results in loss of hepatoportal flow. And third is the grade of the portal hypertension. So greater is the grade of portal hypertension, greater earlier will be the loss of the hepatoportal flow. And fourth is collateralization. Now what happens is you decompress this, but the superior SMV has still got high pressures and the shunt is nearby. So what happens is this SMV will form collaterals to the shunt itself. As soon as, because this is a high pressure system and this is a low pressure system, so it will form the collaterals to the shunt, and as soon as collaterals are formed, all this blood will come back and it will go here and it will be drained, and that will result in loss of the hepatoportal flow. So collateralization is one, the formation of supramesenteric venous and the shunt collaterals. This is one. Second is, I told you about the anatomy, that these pancreatic veins will drain into the splenic vein, right? There are numerous pancreatic veins. But I also told you that the superior pancreaticoduodenal vein and the inferior pancreaticoduodenal vein drain into the supramesenteric vein. So these veins also go into the pancreas. So when the pressure is high, the blood is diverted to these superior pancreatico and inferior pancreaticoduodenal veins, which will eventually come back into the pancreatic veins. And in the pancreatic veins, they form big venous channels, right? So these huge venous channels that are formed because of the back pressure from the suprapancreatic and inferior pancreaticoduodenal vein due to high pressure in the SMV are called as pancreatic siphon, right? So they are called as pancreatic siphon. So this pancreatic siphon is seen in a distal splenorenal shunt. And the only effective way to divide this pancreatic, to prevent this pancreatic siphon is you need to dissect the entire length of the splenic vein and disconnect every single pancreatic vein that enters into the splenic vein. So that will prevent the loss of hepatoportal flow. But that is technically challenging. And the more dissection you do, more lymphatics you disturb, and that will lead to more ascites. Right? So these are all the factors. These are all the problems with a distal splenorenal shunt. Is this clear? Hello? Hello?
Yes, sir.
That hello?
Yes, sir.
Then we move on to the Inoguchi shunt. Right? Inoguchi shunt, when these people did, there were good results, but the same results have not been reproduced by many other surgeons who did this. So here, venous graft is used where the left gastric vein is connected to the inferior vena cava, right? So using a graft, you connect the left gastric vein to the inferior vena cava. This is called as Yanoguchi shunt, right? But the most commonly used selective shunt is a distal sphenorenal shunt. Now, partial shunts. These partial shunts are where they are actually meant to preserve the hepatoportal flow. Similarly, right? So what happens in a non-selective shunt is all the blood from the liver is taken out, so that increases the failure of the liver, aggravates the failure of the liver, and also increases hepatoportal flow, encephalopathy. So to prevent that, what can be done is, this is liver and this is inferior vena cava. This is the renal vein. This is superior mesenteric vein, sporal vein, this splenic vein. You take venous grafts and you make a portocaval anastomosis. You make mesocaval anastomosis or mesorenal anastomosis, right? A vein graft is interposed. So these are called as interposition grafts. Initially, what they used to do is they used to put a large diameter interposition graft. So if the diameter is large, all the blood will come here and the hepatoportal flow will be lost. So what they thought is we'll put a small diameter graft. So they use a PTFE graft of less than 10 mm. So they are small diameter grafts so that a little blood flows through here, a little blood flows through here. So because the blood is flowing through this pathway, it will provide the effective decompression and still some amount of blood goes through the liver. So it is detoxified. So this is interposition graft. These are the partial shunts. So one is portocaval shunt and mesorenal shunt and mesocaval shunt. Small veins can be used or a PTFE graft of less than 10 mm can also be used. So these are partial shunts which eventually turn non-selective shunts, right? So they are basically non-selective shunts. Only difference is that smaller diameter grafts are used so that some amount flows through here and some amount flows through the liver. And the last topic would be, what are the indications? Who are the candidates for liver transplant in such patients? Right? So liver transplant is the only curative therapy for this. All others are controlling therapies. Right? So the liver transplant is, the candidates who are suitable for liver transplant are the non-alcoholic cirrhotic patients. Cirrhosis is because of non-alcoholic disease. So non-alcoholic cirrhotic patients are the candidates. Or if they are alcoholic cirrhotic patients, these patients should be abstinent now from alcohol, from taking alcohol, and these patients should have a deranged functional capacity of the liver, that is FHR is reduced of child, pug, B and C, or their quality of life is reduced, right? So it is either because of the patient has got encephalopathy, or the patient has got extreme fatigue, or the patient has got severe bone pains. So these are the candidates for liver transplant in a variceal bleed. So non-alcoholic cirrhotic patient, abstinent alcoholic cirrhotic patients with poor functional hepatic reserve, and abstinent alcoholic cirrhotic patients with poor quality of life, such as fatigue, encephalopathy, and intolerable bone pain. Right?